കേസെന്താ? ഇയാളിങ്ങനെ പ്രസന്റ് ചെയ്തിട്ടുണ്ടോ?
No. Hello. No, you can talk, ma'am. Yes, ma'am. Yes, ma'am. You can unmute, ma'am. ಮಾಡ್ತೇನೆ.
Okay. Unmute. Can you hear me now?
Yes, ma'am. Yes, ma'am.
I'll keep the phone down.
Okay. Okay.
There is no video. Oh, the background light is not allowing. I'm not seeing in the much better.
Yes, ma'am.
Good evening, everybody.
Yep.
It's still time, so I wanted to know who all are there.
Myself.
Yes, sir, I can see you.
Link on share ಮಾಡೋಣ.
Good evening. Yeah, I can see. I think your picture has come on the screen. Yeah. Good evening, Sanjeev sir.
Good evening, madam. I'm Dr. Srinivas Nutrani here.
Good evening, sir.
Good evening,
Pleased
ma'am.
to
Gopi Sanjeev this side.
Yes, sir.
introducing Dr. Rani Gop, sir. He is Professor Emergency Medicine Department, Sir.
Namaste, sir.
Dr. Kiran Patil, he
Sir,
is
namaste.
Professor Emergency Medicine. Dr. Rajesh R, Assistant Professor.
Sir, namaste.
Dr. Ajay, your student.
Yes, sir. Namaste, sir.
And our postgraduates are there.
Yes, sir. Namaste, sir. I think we should give time because I have given the time as 6:45, so there is still time.
Yes.
Whose idea is this topic, sir? I can see Arjun and Rajat both joining. Good evening, both of you.
Good evening, ma'am. Good evening, ma'am.
Now, good evening, everyone. Coming. Good evening, everyone. Start. Now, I welcome for the webinar from KLE Academy of Higher Education and Research, deemed university, and Jawaharlal Nehru Medical College, Belgavi. A Department of Emergency Medicine is hosting a webinar on empirical antibiotic therapy in emergency department. Our guest speaker, Dr. Varsha Shinde, Professor of Department of Emergency Medicine, Dr. D.Y. Patil Medical College Hospital and Research Center, Pune, will be our host and guest. Now, PPT is there. She is there in the screen. I welcome her with lot of our heartily feelings, and she accepted our invitation and now present here in front of you to talk about the antibiotic therapy. First of all, I thank our beloved Chief Pattern, Dr. Prabhakar Kore sir, Honorable Vice Chancellor, Academy of Higher Education and Research Chairman, KLE Society, Belgavi. Our patrons are Dr. Nitin M. Gangane, Vice Chancellor, Kahir, Belgavi, and Dr. M.S. Ganechari, Register, Kahir, Belgavi. I welcome you, sir, with respect, and our department are very pleased to have you here. I welcome our mentors, Dr. N.S. Mohan Shetty, Principal, JNMC, Belgavi, Dr. M. Dayananda, Medical Director, KLE, Dr. Prabhakar Kore Hospital and MRC. I welcome our Vice Principals, Dr. Rajesh Pawar and Dr. Vishwanath Shetty. I welcome Dr. Arif Maldar, Medical Superintendent, and all our mentors. They are very enthusiastic and they are encouraging. They have given opportunity to conduct this webinar, and I always thankful to them. I welcome our Dr. Shanikov sir, Professor, HOD Emergency Department, and also I welcome our Kiran Patil sir. He is also Professor, Emergency Medicine. I welcome Dr. Rajesh and Dr. Ajay and our postgraduates who have taken a lot of pain to organize this one. I welcome very important our delegates who are the main backbones of this webinar, and I am very pleased to have so much registration and their enthusiastic encouragement and their interest in the subject. It's all our madam has become so much kind enough to give lecture in this day. So I always thankful to her. Now I welcome all our staff members here present, and they are eager to know your subject and your lecture. And I now interest the introduction of your Dr. Varsha Shinde sir, madam, to the all delegates and the faculties. Thank you, sir. Thank you, madam.
Good evening, everyone. It is my absolute pleasure to welcome you all for today's webinar. 2 days back, we celebrated International Women's Day, a day dedicated to honoring the achievements of women worldwide. And today, we have the privilege of hosting an exceptional woman who has excelled in field of emergency medicine, a dedicated educator, seasoned researcher, here Dr. Varsha Shinde. She is highly respected professor in the Department of Emergency Medicine at D.Y. Patil Medical College, Hospital and Research Center, Pune. She has done MD anesthesia from the prestigious BJ Medical College, Pune, and is a fellow of academic emergency experts. With over 22 years of teaching experience, she has been instrumental in shaping the future of medical education. She played a vital role in establishing Department of Emergency Medicine at D.R. Patil Medical College. As a recognized postgrad teacher by National Medical Commission, she has mentored numerous students who have gone on to excel both in India and internationally. Dr. Sindhe career also boasts extensive global exposure with 12 years of service under the Ministry of Health of Sultana Oman, where she gained invaluable international experience and accomplished research. She has published 45 research papers in national international journals with 100 citations to her credit. Her contribution to academic literature continue to shape and enhance the field of emergency medicine. Beyond her academic research achievements, she is passionate educator and faculty member of advanced trauma life support, basic life support, and advanced cardiac life support, playing a crucial role in training healthcare professionals in critical life saving. Today, we are privileged to gain insight from her wealth of experience and knowledge. As we begin this webinar, I encourage you all to engage, ask questions, make the most of the invaluable opportunity. Without further, let us warmly welcome Dr. Varsha S. Sindhe. I request Varsha M. Sindhe to give the webinar of today's. Thank you, madam.
Good evening, everyone. First of all, in the outset, I would like to thank the Department of Emergency Medicine at Dr. Ajay and the HOD of Emergency Medicine Department, Dr. Kulkarni, for inviting me and giving me this opportunity to speak on the topic which is of interest for each and every person who works in the emergency department, not only in the emergency department, but also critical care department, microbiology, pharmacology, internal medicine, so many departments which are interrelated to this topic. So I am very grateful for giving me this opportunity. I hope to do the justice to this topic. So let's start. At the end of this lecture interactive presentation, the objectives are we will define what is empirical antibiotic use in the emergency department, what are the challenges which an emergency physician faces, the basics of antibiotics we will see, the principles of antibiotic therapy, importance of timely and appropriate choice of antibiotic, the factors to consider in choosing the right antibiotic for the right patient, and antibiotic stewardship. I will also have a word about the recent advances and rapid diagnostics in the present day. So antimicrobial drugs are the greatest contribution of 20th century to therapeutics. Before that, medicine could do only palliative job. As the antibiotics came, it became a curative therapy, and penicillin was a miracle drug. But soon, the antimicrobial started developing resistance, and today, antimicrobial resistance is rampant in India, with about 12 to 59% of E. coli being extended ESBL producer, that is extended beta lactamase producer. So that is, they don't work with beta lactamase drug, and up to 30% being carbapenemase producer. So they are not even giving a response to meropenem, imipenem kind of drugs. So it's a very serious concern. Klebsiella pneumoniae has emerged over the last few years as a very highly resistant pathogen, making up to 50% of the resistance to carbapenems and rapidly increasing to even polymyxin B. So what are we left with? That's a really big question. We don't have the statistics of death, but certainly from US, 270,000 people, they die of sepsis every year. Of that, about 35,000 deaths are because of the drug resistance. So if you look at this burden of sepsis, starting antibiotic therapy is a decision. I say it is a decision which a clinician faces at bedside every day. So what is empirical antibiotic? Empirical antibiotic is defined as the initial antibiotic regimen which is selected when you do not have definitive microbiological pathogen identification or any culture report. So you don't have the susceptibility, you don't know what the pathogen is. That time what antibiotic you give is called as empirical antibiotic. So what is the challenge which emergency medicine faces? Because when the patient first presents to emergency department, we have no clue about whether it is an infection in the first place or whether it is a non-infectious presentation. This is the most important challenge. We do not have the lab results and the presentation can be very severe. So as you can see in this picture, it is the sepsis which is in the middle, which has all the characteristics of systemic inflammatory response syndrome, all the characteristics because it is the common. It is caused by infection. Whereas there are certain other parameters like trauma, burns, acute pancreatitis, say pulmonary infarct, heart failure, all these, they will have some features of SIRS who do not require the antibiotic therapy. But the presentation is such a manner that you may mistakenly give antibiotics for this diagnoses, and which is wrong. So the choice whether it is an infectious pathology requiring antibiotic therapy or whether it is non-infectious pathology is the most important challenge, first of all, which an emergency physician faces. Then coming to the choice of empirical antibiotics, Surviving Sepsis campaign when it came, it advised you that if the patient comes in sepsis or septic shock, you should give broad spectrum antibiotics when the patient first presents. So the principle was you hit hard and then after collecting the cultures, by the time you get the culture reports, you can de-escalate. That was what the advice. If you go through the Indian guidelines, what the ICMR says, the 2019 guidelines, they say that only 5 conditions in which the empirical antibiotic is advised. And those are febrile neutropenia, septic shock, community-acquired pneumonia, ventilator-associated pneumonia, and necrotizing fasciitis. See that only is written in capital letters, and this is what our guideline says. So coming to the topic itself, that is how do we choose the empirical antibiotics? So first and foremost question is, what is the source of infection? So whether the infection is pneumonia, lower respiratory tract, whether it is urinary tract, whether it is pyelonephritis, whether it is skin and soft tissue, or whether it is meningitis. So what is it? Or whether it is catheter-related bloodstream infection. So that is the first and foremost thing. So the clinician, first of all, should go through the patient's history. What are the presentations? What the patient is complaining of? Do a thorough clinical examination. You can take the help of point of care ultrasound, which is at the bedside available in the emergency department itself. Point of care lab investigations, which you have either to rule in or rule out the diagnosis. Like if you do BNP, TROP-I, TROP-T, they will help you to find whether it is non-cardiac cause, which is masquerading. You also have arterial blood gas at the bedside and X-ray chest. To this, I will come at the end of my lecture that you also have rapid diagnosis, which will pinpoint to the organism which you are wanting to know. At this stage, we are first focusing on the source of infection. Then the next question comes based on the local epidemiology. When you are working through the same institute, what is the probable organism which is causing or giving rise to this infection? Next question to consider is what is the severity of infection? Whether the patient is presenting in septic shock or whether the patient is presenting with stable vitals in order to give some more time for the clinicians to rule out what are the masquerading other diagnoses which are non-infectious. So it depends on this another factor. Then whether the infection is community acquired or the patient has undergone some treatment in the immediate past. He has received some antibiotics in the near some neighboring hospital and then you has come to your institute. So that becomes a healthcare associated. And as all of you know, the bacteria which are with healthcare associated infection are the notorious multi-drug resistant organisms. Whether the patient has indwelling devices, say a Foley's catheter for a long time, which he has not changed, or a central line or a dialysis catheter. So usually with this, the reaction is there is a biofilm which is formed, and the organisms, they slowly grow in this biofilm, and they are not available for the antibiotic to act. So in this case, we need to remove that indwelling device. Then what are the patient comorbidities? What is the immunity status? We are going to see each and every factor in details. Is it only a bacterial infection, or whether it is because of the treatable viruses or fungi or protozoa, in which case the antibiotics are not going to work. So overall, with this, it is a clinical judgment which an emergency physician takes. So how do we guess? The first question was how to guess the source of infection. So if it is a lower respiratory tract infection, the patient will come up with cough, fever, breathlessness, pleuritic chest pain, signs of consolidation on clinical examination, and the point of care ultrasound will help you to have certain signs, lung sliding, gray hepatization, shred sign, all those will point at the pneumonia. Urinary tract infection, the patient will come up with dysuria, hematuria, urgency, loin pain. If it is meningitis encephalitis, it will be fever, altered sensorium, convulsions, and you may get signs of meningeal irritation. Gastrointestinal system, it will be abdominal pain, distension, nausea, vomiting, diarrhea, and dehydration. Skin and soft tissue infections, erythema, edema, ulceration, cellulitis, and maybe abscess formation. If it is genital tract, in females, it may be lower abdominal pain, vaginal discharge, backache. In male, it can be scrotal pain, tenderness, dysuria, incontinence of urine, and prostatitis. Intra-abdominal infections will present with abdominal pain, tenderness, rigidity, rebound tenderness. So that will point at the source of infection. I have just taken the common infections which we face on day-to-day basis. What is the possible organism? So actually, at your own place, you have to study. It is an epidemiological study which will tell you that, for example, if it is pneumonia, the most common cause of pneumonia is Streptococcus pneumoniae, H. influenza, Staphylococcus klebsiella. So all these, and atypical organisms which are located intracellularly, Mycoplasma, Chlamydia, Legionella. So they may be culture negative, and there is a certain group of antibiotics only will be tackling these atypicals. Urinary tract infection, most common organism is E. coli, followed by Klebsiella proteus, so Enterobacteriaceae. It can be also because of the Enterococcus. Meningitis, the most common organism is N. meningitidis, Streptococcus pneumoniae, but it can be Listeria monocytogenes, especially patients over the age of 50 years and alcoholics. So you need to cover with ampicillin for these patients, and Haemophilus influenzae. Whereas skin and subcutaneous infections, it will be caused mainly by the gram-positive cocci, streptococci, or staphylococci. What are the common infections which an emergency department faces? It is usually the community-acquired pneumonia, uncomplicated UTI or complicated UTI, or skin and soft tissue infections, intra-abdominal infections. So local knowledge of the common organisms and infections is very important. So these are the Indian guidelines on the antimicrobial use, which are freely available on the internet. And I feel besides, everyone should go through these guidelines rather than IDSA guidelines, which are published by US. And you should also know about your own institutional epidemiological studies and the antibiotic. So if the host factors, if the host is immunocompromised, how do you recognize? So if the patient is diabetic, has got a renal failure, or is with some cancer, malignancy, or is on steroid therapy for any reason like rheumatoid, or if it is HIV with AIDS and low CD4 count, or if the patient has undergone organ transplantation. So these are usually on immunosuppressant therapies. And if the patient has if it is splenectomy, patient has undergone, then he is prone for capsulated organisms infecting him. So usually they are given pneumococcal vaccines also, or whether there is granulocytosis or aplastic bone marrow. So all these compromise immunocompromised hosts. If it is cell-mediated immunity which is compromised, these patients are prone for tuberculosis, fungal infections, and atypical organisms. All these immunocompromised patients, they have deceptive presentation. They do not present in an ideal manner. They may not have fever. They may not have leukocytosis. So if you do not give them cidal drugs, they deteriorate very fast. Usually, the static drugs do not act or they are insufficient for considering these patients. So these are the factors which the immunity of the host matters. Spectrum of antibiotics. You must know what is the spectrum on which my antibiotic which is prescribed is acting. For example, penicillin, which is a proto-drug. Nowadays, nobody is using, but I have purposely taken because the antibiotics, they start with penicillin. So usual spectrum of penicillin is gram-positive cocci, beta-hemolytic streptococci, viridans, and streptococcus pneumoniae. Nowadays, the advanced or augmented like amoxicillin, ampicillin, all these penicillin versions are being used. So these are the spectrum of antibiotics which you should know. Piperacillin tazobactam, it covers gram-positive as well as gram-negative as well as some anaerobic organisms also. You should also know about cephalosporins, that first generation cephalosporins are best for gram-positive organisms. Second generation will cover gram-positive as well as some gram-negative. Third generation will cover gram-negative more, but the gram-positive spectrum really goes down. Fourth generation and fifth generation is mainly for the resistant bacteria. You should also know about the mechanism of antibiotics. So I am just going to take 4 mechanisms. Cell wall inhibitors, they are the cidal drugs which consist of beta-lactam, penicillin group, cephalosporins, carbapenem, fosfomycin, and bacitracin. Nucleic acid inhibition, quinolones, metronidazole, nitrofurantoid, and rifamycin. Protein synthesis inhibition is done by aminoglycosides, though they are still cidal drug. Macrolides, tetracyclines. Tetracyclines are static drugs. Inhibitors of metabolism, sulfonamides and trimethoprim. Nowadays, nobody uses it, but believe me, in US, it is still the drug of choice in many conditions. Coming to pharmacodynamic issues, considerations are very important as you are giving any antibiotic therapy. In the left-hand side, you can see the diagram that as you give the antibiotic to the patient, initially it achieves a peak. There is something called as minimum inhibitory concentration. So if you consider beta-lactam antibiotics, the bactericidal activity is time dependent. So it is related to the time that the minimum inhibitory concentration is present in the tissues and plasma. The maximum amount of time that the plasma level can fall below MIC is around 40% of the dosing interval. So during this, the bacteria will grow, and then again when the peak comes, they are subjected to the cidal effect of the beta-lactams. So if the patient is really sick, continuous infusion is a better way or a preferred way from the pharmacodynamic point of view. And these beta-lactams, they have reasonable tissue penetration. On the slides I have given at the down, the references from which I have taken. Pharmacodynamic continues for aminoglycosides. The bacterial kill is maximized by attaining higher maximum concentration. And it is the ratio of Cmax by MIC, which is very important as far as the activity of aminoglycosides is concerned. So if you want to give gentamicin, it is once a daily dose, which will act better than it is divided into 2 to 3 doses. And if there is renal dysfunction, the loading dose essentially remains the same. It is the maintenance dose which gets affected, and it depends on the creatinine clearance of the patient. So you have to calculate the creatinine clearance, and if the creatinine clearance, as I have given in the slide, either you can give the same dose at longer intervals, or you can give a smaller dose at a smaller interval. If the patient is undergoing hemodialysis, naturally the nephrologist is there to look after, but we have to remember that sometimes they will give the drug at the end of the dialysis, and the initial dose, loading dose, may be increased because there is third spacing. Some antibiotics have got post-antibiotic effects, especially aminoglycosides and fluoroquinolones. They have the post-antibiotic effect. Why do they have? is because they alter the protein synthesis or nucleic acid synthesis. That's why it takes longer time for the bacteria to regenerate these elements than the components of cell wall. Pharmacokinetic considerations, that is what the body does to the antibiotic. So aminoglycosides, glycopeptides like vancomycin, they have distribution more extracellular, extravascular, and they have less tissue penetration. So they are not the drug of choice in solid organ infections where third spacing is there. If third spacing is there like edema, a dialysis patient, so the initial dose is higher than normal. So if you consider beta-lactams and aminoglycosides, they are hydrophilic. So they have less volume of distribution. Their clearance is by kidney. So there is a loading dose and dose adjustment in renal failure. If you take fluoroquinolones and macrolides, they are lipophilic. So their tissue penetration is very good. Their clearance is mainly by liver. Volume of distribution is high. So there is no loading dose. There is only one dose and the dose adjustment is required in liver diseases. We should also take into consideration tissue penetration. If the tissue penetration is not there for that antibiotic, it is of no use. For example, if you take piperacillin tazobactam, it should be avoided in patients with suspected central nervous system infections because tazobactam does not cross the blood-brain barrier. TJ cycline should be avoided in presumed bacteremia because it is a static drug and there is a low serum concentration. Daptomycin should not be used. Daptomycin is a drug used for MRSA, but it should not be used for MRSA pneumonia because the drug gets activated by the surfactant in the lungs. Then we should also assess whether there is a risk for resistant organisms. So as you all know that if the patient has already taken any treatment outside or if the patient is having ICU infection, means after long-term stay in the ICU or whether it is ventilator-associated pneumonia. So these are the examples. So I'm just focusing on these two factors, methicillin-resistant Staphylococcus aureus. So recent hospitalization, residence in long-term facility, recent surgery, hemodialysis, prior antibiotic treatment, and high Apache score. These are the risk factors for MRSA. For vancomycin-resistant enterococci, immunosuppression, neutropenia, renal insufficiency, ICU stay or oncology ward stay, and prior antibiotic therapy are the risk factors. So if you take a good history, you should realize that whether I should cover these organisms or not. The next question is when to administer antibiotic therapy. So sepsis guidelines, they say that if the patient is in septic shock, antibiotic should be given within 1 hour. So 1 hour means it is still the emergency department stay. That's the reason why this topic is very important for EM point of view. Every hour delay in antibiotic administration from the time of hypotension onset will decrease the survival by 7.6%. So that's a very high number. Reference is given at down. If the patient comes with sepsis, but still there is no shock, still you have to give prompt antibiotic therapy in exceptional infections like bacterial meningitis. If you are delaying or by some reason your lumbar puncture is getting delayed, you should first give the antibiotic and then you can undertake the lumbar puncture, provided, of course, there are no contraindications for it. So giving the first dose of ceftriaxone, say 2 gram, or along with that vancomycin is very, very important from the bacterial meningitis point of view. Also, giving steroid cover before the antibiotic also equally is important in case of acute bacterial meningitis. 32% of the patients with suspected sepsis have non-infectious cause when additional data is collected. So this is one of the study that 32 means 1/3 of the patients, the clinical picture looks like infection and that's why you give antibiotic. But 1/3 of the time, it turns out to be non-infectious etiology. So rushing to the judgment has definitely got adverse effect and we should be very cautious in taking this decision. So what do you mean by appropriate antibiotic? So it is defined as antimicrobial coverage that provides adequate bactericidal activity against all likely pathogens at the clinical infection site of interest. So a study was done by Kumar and colleagues the reference is given. It is published in Chest 2009, that they studied retrospective analysis of the antibiotics given. 80% of the time, appropriate antibiotic was given and the survival was 52%. And 18% of the time, inappropriate antibiotic was given, where the survival was only 10%. So odds ratio is 9.1. So this is very important to give appropriate antibiotic. Next thing is source control. So if the patient is having any abscess at any place, it is very important that we should give the surgical consultation and the abscess should be drained. Without that, the patient will never recover. Same thing for the indwelling catheters. Indwelling catheters needs to be removed if the patient has one. Then only the antibiotics will act. I am just sharing with you what are the common antibiotics which are given. So ceftriaxone, gentamicin, amikacin, ciprofloxacin, vancomycin, and meropenem, as it is shown in this slide. We should know about what is the toxicity of antibiotics as such. So some antibiotics have got high therapeutic index. So if you give 2 to 3 times the dose, there is no effect. For example, cephalosporins, penicillins, they have high therapeutic index. But there are other drugs like aminoglycosides, polymyxin, vancomycin, they have got narrow therapeutic index. And we should be really careful when we are giving these drugs. All the antibiotics are having hypersensitivity reaction. If you have read toxic epidermal necrolysis and Stevens-Johnson syndrome, all these are related to, in addition to anti-epileptics, antibiotics are the first drugs. So we must remember, and especially with the penicillin group of drugs, hypersensitivity reactions are very common. Super infections. Again, this is a major side effect because when we give antibiotics along with the pathogenic organisms, the normal microbial flora which the patient is having gets killed. So the organisms which are not killed by that bacteria, they suddenly take surge and they proliferate. For example, fungi. So if you give a broad spectrum antibiotics, these infections, which are the normal commensals, they start becoming pathogenic, and that is called as super infection. Drug resistance is another important problem if you give indiscriminate use of antibiotics for the conditions for which it should not be given. Suppose, for example, if it was a non-infectious cause and if you have given, you should immediately stop that. Or when you come to know that it was viral infection, we should immediately stop the antibiotic course. So this indiscriminate use has given rise to drug resistance, and it is today's very serious problem. Nutritional deficiencies. Lot of good bacteria, they are making vitamin B complex, vitamin K, all these things. So if the antibiotics are given, they get killed and the patient suffers from nutritional deficiencies. Masking of an infection. When you give antibiotic, if the patient is developing some infection, it gets suppressed. But after that antibiotic is over, maybe that time it got masked and then seriously it comes up. So this is a very important toxicity or side effect of antimicrobial therapy. And Clostridium difficile infection. So it releases the enterotoxins. And this is a major problem if you give indiscriminate use of clindamycin and all broader antibiotics. Which I'm just focusing on the drugs which we give every day, like ceftriaxone, we give right and left. So hypoprothrombinemia and bleeding is a big risk with ceftriaxone. Otherwise, it's a very good drug. If there is renal problem, the metabolism occurs by the liver. And if there is liver problem, the metabolism gets shifted to kidney. So it is relatively a safe drug and has got a long half-life. So you can give either once a day or depending on the severity, twice in a day. Aminoglycosides are ototoxicity, nephrotoxicity, vestibular nerve damage. So these are common side effects. Tetracyclines, liver and kidney damage. Vancomycin can cause hearing loss, red man syndrome, and kidney damage. So targeted real-time early warning sign has been developed in ICU patients to predict the development of septic shock, which could be potentially used to identify patients at high risk for developing septic shock. I like this article. It is published in 2015 and a lot of publications have been done on this. So they are predicting which patient will develop into septic shock from the EM presentation. But they are making use of machine learning and AI. So I request that all those who are EM physicians can look up into this article, and if you can also undertake a study. So that was the thing. I proudly come across this Ministry of Health launching the India's first indigenous naphthromycin to combat drug-resistant pneumonia. So it is just released on last November, that is 3 months back, by the Ministry of Health in Delhi. And it is one of the nice drug. It has got 10 times efficacy with just 3 doses to combat drug-resistant pneumonia. It is 10 times more potent compared to azithromycin. So I just wanted to share it. Coming to the role of rapid diagnostic in the emergency department. What if we could just identify what organism has caused this infection within 1 or 2 hours in emergency department itself? And technology is the answer for this. Already it is in use. So FDA has recently approved Tri-Verity test system, which is a molecular diagnostic test. It measures the gene expression levels associated with the response to infection, immune response to infection. It uses artificial intelligence and machine learning to create the critical scores and how likely whether the patient is getting bacterial infection and what is the risk of developing a septic shock or a severe illness. It is based on sepsis shield study, which involved 1,200 patients across 22 sites. So it is a milestone in precision medicine. We also have in Pune availability of this BioFire film array panels. So I have shown the picture on the right hand side. FDA has cleared this panel for viruses, bacteria, parasites, yeast, and antimicrobial resistant genes. This report, you have to fill the specimen and the report is ready within 1 hour. So it is just like the point of care lab, which is we have to fill the specimen and the report is there within 1 hour. Only thing is the possibility of whether it is inoculation or whether it is pathogenic, little bit of things is there. But I discussed this with one of the colleague which is using it in Pune in a private hospital. He said the results are really good. Still, we have to send the cultures, but this is one thing which we can use. Left hand side, I have put one slide that ICMR has given some guidelines. It's a booklet, 2025 only, this year's publication, for validation of rapid diagnostic test for the pathogens identification. So they have given clear-cut guidelines for what all things are required before you validate and use these equipments in the emergency department clinically. Another thing is FDA has authorized artificial intelligence and machine learning tool for sepsis prediction, development and validation. This is a paper which is published just last November 27, end of November 2024. It is published in New England Journal of Medicine. And the sepsis immunoscore is a comprehensive, multi-dimensional AI and machine learning tool that combines demographics, vital signs, clinical laboratory tests, and sepsis-related laboratory tests to assess the risk of sepsis and the risk of adverse outcomes. So this is where the world is going. Coming to the topic of antimicrobial or antibiotic stewardship in emergency department. See, it is defined as systemic measurement and coordinated interventions which are designed to promote optimum use of antimicrobial agents by advocating selection of appropriate antimicrobial drug regimen, including the dosing, duration of therapy, and the route of administration. It is focused on to optimize the clinical outcome while minimizing the unintentional consequences of antimicrobial use, like the drug resistance. Mainly, it is the drug resistance. So what is done is whoever is prescribing the antibiotics, there is a team of microbiologists, the physicians, critical care intensivist consultants, and also the clinical pharmacists. They take the audit of prescriptions which are given. They go through the whole file, what patient is, what medications the patient is having, whether there is any drug interaction, which is either increasing or decreasing the dose of that antimicrobial, whether liver function is abnormal and whether the drug is excreted by liver, kidney function, so whether the dose is appropriately made or not. So all these audit helps for appropriate dosage of the drug, and according to the institution, either they are given the authority that they can change or they give the suggestions to the treating physicians so that appropriate drug is given for the appropriate duration in the appropriate way of administration. After a single day of imipenem, a French study demonstrated that patients grew imipenem-resistant bacteria in their feces. Just one day of this imipenem therapy. So there is an overgrowth of resistant bacteria, and it is a natural consequence of broad spectrum antibiotic use. This is termed as collateral damage. Inadequate dosage of antibiotics also gives rise to overgrowth of resistant organisms. So when we initiate the empiric therapy, when we do not know, it should be followed by de-escalation when the culture results are in our hand. It is very important to have local protocols because it is not the national guidelines which is telling you what to give. It is your institutional local specific guidelines which will be telling you which antibiotics I should give, what is the most probable microorganism which I am dealing with. So, antibiogram. So, antibiogram is the summary of antimicrobial susceptibility data depending on the bacterial isolates which are recovered from the microbiology lab over a period of say 1 year. So it is different for emergency department. It is different for critical care medicine, ICU setup. It is different for the ward setup. So each and every one of us who's prescribing antibiotic should be aware of the antibiogram so that appropriate antibiotic therapy is given to the patient. So with this, I will be discussing just two cases and two multiple choice questions. So the question one, I want interactive response from the audience. A 20-year-old lady comes to your department, emergency department, has no comorbidities. She comes with a history of cough and fever since 1 day and has now developed breathlessness. On examination, patient is febrile, 38, heart rate is 124, blood pressure is 80 by 50 millimeter of mercury, oxygen saturation is 84% on room air, and respiratory rate is 36 per minute. This is the X-ray which is put on the slide. So what empiric antimicrobial would you like to give? Or would you like not like to give antibiotic? Any thoughts? You can unmute and please tell your thoughts. Anybody?
Good evening, ma'am. This is Dr. Suraj, ma'am, from
Yes, please.
SDA Medical College. So, as a patient is in hypoxia, ma'am, with tachypnea, with start looking at the X-ray, so
Yes.
I would hit hard. Start with piperacillin tazobactam as my first drug of choice.
So, what has given you this? See, this looks like a pneumonia patch.
Yes,
Patient
ma'am.
is a young patient, no comorbidities, so looks like a community-acquired pneumonia,
Yes, ma'am.
right? Yeah.
Yes, ma'am.
Patient is in septic shock.
Yes, madam. Definitely.
So first, you will not call it a septic shock unless you have given the fluid resuscitation. Am I
Yes,
right?
yes, ma'am.
So
Definitely.
first, surviving sepsis guidelines are telling in within 1 hour, you have to give the fluids first, and
Yes,
then
madam.
if required, vasopressors, right?
Yes, madam.
Next comes that you will be collecting the cultures within 1 hour, and then
Yes, madam.
thinking
Yes,
of
madam.
giving in the first hour the antibiotic.
Yes,
So the
madam.
most common organism for pneumonia is first most common organism is it
Streptococcus, ma'am.
Streptococcus pneumoniae. Streptococcus pneumoniae, very good. And additionally, you have to cover the atypical
Atypical coverage.
bacteria. So atypical bacteria are covered by
Ma'am, broad spectrum, again, considering atypical, I think piperacillin tazobactam would cover both, ma'am.
atypical is not covered. See, atypical, they are called as atypical because they are located intracellularly. Okay.
Okay,
They
okay, ma'am.
are
Okay.
amenable to be to only, what are the two drugs? It is the azithromycin or
Macrolides. Yes, ma'am. Yes, yes.
macrolides or furoclonus, like
Fluorocarbon.
respiratory
Yes,
furoclonus
yes.
you can give. So
Yes,
they
ma'am.
have a very good diffusion intracellularly.
Yes, ma'am.
So you have to focus on Streptococcus pneumoniae, right? Which is the
Yes,
most
ma'am.
common. So what is the best drug to cover Streptococcus pneumoniae? It is still active for which least possible drug? Anybody differs from his opinion?
Sure.
Yes? Ceftriaxone, yes. I think for me, I would have given ceftriaxone and Azi as a combination to treat this patient. Okay? Because piperacillin tazobactam is more useful for gram-negative organisms.
Right,
Are you
ma'am.
getting my point? Also,
Right,
you
ma'am.
have to cover the atypical organisms without fail because it is a community-acquired infection. I would have agreed if this patient was diabetic, immunocompromised, or has taken some treatment outside and then has come.
Right, ma'am. Right, ma'am. So
Yeah,
initially
so
start with ceftriaxone with azithromycin.
after taking the cultures,
Yes,
you can start
definitely,
so that
ma'am.
you can narrow down later on. But atypical
Okay.
coverage
Yes,
is
ma'am. Yes, ma'am.
definitely required.
Yes, ma'am. Yes, ma'am.
So
Thank
we
you, ma'am.
have to start thinking in terms of what is the source, what is the most probable organism, what the spectrum it will respond to, what is the best, the smallest antibiotic which I can give and it will cover. And like that, you have to give the treatment. So am I clear? Any of the senior faculty wants to have some opinion? Please, you can have your opinion. I will be very happy to listen to you, sir. Anybody?
With no comorbidity, young lady must
Yes, sir.
be even second because it's septic shock.
Yes.
Always we prefer second line of antibiotics in
Okay.
septicemia. First line of antibiotics are very simple antibiotics, which are preventive measures and small infections like that. Second
Yes.
line of the drug of the choice of drug, and
Yes.
which should act on both gram negative and gram positive
Okay.
organisms. So that's why the cephalosporins are the drug of choice here. There's a
Yes.
second or third generation can be preferable here.
Yes, sir. So same thing. I was also of the same opinion. So in the for the students, I just wanted to focus them that we have to still remember the sepsis guidelines. So fluid resuscitation will come first, oxygen will come first. If they require NIV also, that also should come first. And you will only call septic shock when the fluids are been given. Because the definition says that after the fluid resuscitation, if there is still requirement for vasopressus, then it is septic shock. Or the arterial blood gas showing the lactates more than 2. So that was the thing. Next case is 62-year-old female. Easy case. It is from the UG side. Frontal headache, complaining of frontal headache, has got a high-grade fever, yellow nasal discharge since 2 days, and there is a frontal sinus tenderness in between the eyebrows. The X-ray is clearly showing frontal sinusitis. The patient is on amitriptyline 75 milligram once a day for 1 month for her mental depression. Her doctor decided to give her moxifloxacin 400 mg OD. So, is the choice of antibiotic appropriate? If yes, what could be the considerations for selecting moxifloxacin? And if no, please give the reason for your no and give the alternative antibiotic which you may consider. The forum is open for discussion, please. Any resident, anybody can please. Frontal sinusitis. So, sinusitis, what is the most common organism? Yes, please.
Usually staphylococcal infection or streptococcal infections are common in sinusitis. So patient is on amitriptyline and that is having a problem with aminoglycosides interactions also. So some of the negative that MRS resistance drugs are to be used here because Staphylococcus and Streptococcus infections are MRS resistance antibiotics are preferable here. So if it is in normal common infection, recurrent infections, we have to see for resistance. Already any antibiotics have been taken by the person, already resistance occurs. So we have to avoid those antibiotics and we have to start a new line of antibiotics. So preferably here, what we see is MRS resistant antibiotics like same cephalosporins only first. Next is the gram positive like Piptas or something like that, which is resistant antibiotics.
So this was
Moxifloxacin,
actually the first episode. The lady has got first
first,
episode of
first
frontal
episode,
sinusitis.
first episode we can try for normal cephalosporins or amoxicillin, Clavinac antibiotics.
I want actually the students can try. Can you anybody? Dr. Suraj can also try.
Yes, come on, tell.
Yeah, please, please.
Come, talk. Talk there only, yes. Thank you.
Yeah.
And since it's a 62-year-old female with first episode of sinusitis, a simple antibiotic would suffice, or beta-lactam, like amoxiclav would have sufficed.
Yes.
Like no need to give a higher end antibiotic for
Very
a
good.
minimal
Excellent.
infection.
Yes. So is it the correct choice which the physician has given, moxifloxacin? Do you agree?
No, don't agree, ma'am.
Okay. So, and she has given that simple antibiotic. See, moxifloxacin, this infection is basically caused by just gram-positive cocci. Okay, most commonly. So, moxifloxacin excellently covers the coverage. That is not an issue. Actually, the issue is with the patient. If you go through the history, patient is taking amitriptyline 75 milligrams. So,
Okay.
it increases the QT interval.
Yes.
And if you give moxifloxacin, there is a very high chance of malignant arrhythmias. So there is a drug interaction. So even if the spectrum is correct, the drug is going to cover these bacteria, still the patient is prone for ventricular arrhythmias like torsade. So this is not a good choice for this patient. So as she said, the answer is correct. You can give amoxiclav or ampicillin. Plain gram-positive coverage is enough for this patient.
Even first generation of cephalosporins also can be. That's what.
Yes, can be given. First generation, cefalexin. You know, we can give first generation cephalosporin. Second generation also can be given, cefuroxime. Oral can be given. So that was the thing. So I wanted to point out drug interactions, especially people die because you must have heard that drug interaction, especially QTC prolongation. So all these antidepressants, you have to be very careful with drug interactions and what antibiotic we are giving. Next is a multiple choice question. So please, all the residents, you can easily tell. 22-year-old woman presents with second visit to emergency department 3 days after being evaluated for dysuria, despite being prescribed nitrofurantoin. Review of her urine analysis three days before shows that there are multiple WBCs, negative pregnancy test, negative culture. Which of the following may be a complication of this if not treated appropriately? So young female, second visit, first visit was for UTI, uncomplicated UTI, so she was prescribed nitrofurantoin. This is the culture report that multiple WBCs, she is not pregnant, culture negative. So what is the complication of this if not treated appropriately? See, all the residents should try because now OSCE is NMC has advised us to include OSCE. Yes, which is the complication? Yeah? Can you tell loudly? I missed it.
Pelvic inflammatory disease.
Excellent. So what is the organism which you are thinking of?
Gram negative.
No? What is the organism which gives rise to pelvic inflammatory disease? Anybody? Can you guess the organism which can cause sterile pyuria? This becomes sterile pyuria because culture is negative. Anyone? Yes?
Trichomonas vagina.
That is a protozoa. That is not covered by antibiotics.
Bacterium. E. coli.
So it is a chlamydia. Chlamydia is an intracellular. So that's why culture negative. And it gives rise to, it's a common cause of pelvic inflammatory disease. So good effort. We go to the last MCQ. Which of the following antibiotics can potentiate the effect of titanospasmin when administered? Which of the antibiotic will potentiate the effect of titanospasmin when it is administered?
C. Metronidazole.
Yeah, C. Metronidazole. Anybody else differs from that? Anyone? Any comment? Yes, please.
D. Penicillin.
Yes, actually it is the penicillin because metronidazole is the drug of choice for anaerobic infections like tetanus, and penicillin is shown to potentiate the effect of titanospasmin when administered. So it is a little tricky question. That's why I just chose it, because I thought that some people may get diverted and go for metronidazole. But metronidazole is the therapy, and it is the penicillin which potentiates the effects of titanospasmin. So I come to the take-home message, that is, starting of antimicrobial therapy is a decision a clinician makes daily at the bedside. Right antibiotic choice for the right patient in the right dose and in the right duration needs consideration. Empirical antibiotic therapy are a part of one hour bundle in sepsis. Knowledge of the source, possible microorganism causing it from the epidemiological survey, the urgency of administration, all factors they play an important role. The antibiotic microbial therapy should be tailored to each patient. Rapid diagnostic tests which are coming up technologically may help us in taking this decision. An emergency medicine physician plays an important role in antibiotic stewardship. With that, these are my references in addition to the references which I had put at the end of the slides. I thank you all for patient listening. Any comments from the experts, and the forum is open for discussion.
Thank you, madam. So nice talking and so nice interactions also. And here some questions have been posted in the chat box, that how to decide the duration of antibiotics to be given.
See, the Indian guidelines are definitely telling the duration of antibiotic therapy. I want each one of us to go through that. They are telling that not more than 5 days. For some infections like pyelonephritis, they are telling for 14 days. And they are telling that more than enough antibiotic duration, if it is given, that is one of the main factor for antibiotic resistance. There are exceptional conditions like infective endocarditis, where it is given for 4 to 6 weeks. And as emergency physician, if we practice only EM, then the duration of therapy doesn't come into picture, because we are only there, like in my department, we keep the patient, we make it a policy as only 6 hours, though many times it exceeds to say 12 hours, 24 hours also. But more than that, stopping of the therapy doesn't come under EM. But this guideline, Indian guideline, is a really good document which is specifying for each condition how much to give. It starts with just 5 days and it goes to maybe 7 days. Some conditions it is 10 to 14 days, and only very rare conditions it is 4 to 6 weeks. Very nice question. Anybody else?
Another question is it is it preferred to give IV antibiotic, but if only IO line got from ED?
The intraosseous line is always a replacement of intravenous line, because that is recommended universally. When you are not able to get IV line, you can always get in intraosseous line, and we have done that. Once you give say 100 to 200 ml of fluid, definitely you get a peripheral veins which come up, and you can get a IV access. It never happens that you are not able to get it only, excepting for say cardiac arrest. If the patient revives, ROSC is achieved, then next plan comes. But on an average, with hydration, peripheral veins do come up. At least you are able to get a cubital vein.
In special cases like children,
Yeah,
neonates.
in children, see, I have put in the intraosseous line in children only. Neglected child, very severe dehydration, all the peripheral veins are collapsed, and we got a intraosseous. After 150 ml of fluid, the peripheral vein came up.
Another question they have asked is hemodialysis. Does loading dose should be repeated?
See, hemodialysis, actually, we really don't have to worry because nephro person is always there. And they are only taking the good care of, because after all, we give when the creat is impaired, we also take them into consideration. We have, most of the hospitals have the super specialty. So you can calculate the creatinine clearance. The loading dose never gets affected. Usually it may be sometimes high, because we usually discuss with our nephrologist. Also, I was a ICU consultant in a corporate setup. That time, they will tell that the dose for a dialysis patient, they will give at the end of the dialysis so that the drug remains in circulation. Because
A few
kidneys are
more,
impaired.
few
Can I
more
can I
questions.
come in, please? Can I come in, please? I'm OP Sanjay here from Lucknow.
Yes, sir. Yes, please. Yes, sir. You
Please,
can
sir.
come in,
Please.
please. Sir is also emergency department professor. So welcome, sir.
Welcome,
I
sir.
am
Please.
associate professor only. Okay. So as far as the repetition of dose is concerned after hemodialysis, I wish to submit humbly that it is the kind of antibiotic pharmacokinetics which decides that whether after hemodialysis the bolus dose or loading dose is to be repeated or not. As for example, we have one vancomycin and we have one teicoplanin to cover MRSA. If patient is on teicoplanin, we do not need to repeat the bolus dose after hemodialysis because it is not filtered much in diacylate. But if patient is taking vancomycin, as vancomycin gets totally filtered in diacylate, it needs to be repeated either at the end of hemodialysis or just after hemodialysis. So it
Yes.
depends on the pharmacokinetics or the kind of
Yes.
excretion by hemodialysis, which necessitates that whether the antibiotic dose should be repeated, I mean bolus dose should be repeated or not.
Yes, sir. That's why I had covered one slide in which I had shown the pharmacokinetics, which drugs are getting metabolized by liver and which are getting purely excreted by kidneys. So
Yeah.
aminoglycosides are one drug which we have to always consider because they are totally renal excretion. So they
It
definitely get
also
affected.
it
Yeah,
also
absolutely.
depends upon the duration dose at what time it was given.
Yes.
Previously, it was given before half-life is getting metabolized.
Yeah.
After hemodialysis, you can give full dose only. If it
Yes.
is immediately, already receptors have been taken away the antibiotics, and hemodialysis might have less effect on that. So that's
Yes, so
why.
all those factors. So mostly, actually, I am even more this thing that the nephrologist, we have to just give proper over that when
Yes.
have you given the antibiotic.
Yeah.
Yes, it has to be analyzed first. Factors affecting all the things has to be analyzed, and then it can be given, I think.
Yes, sir. Yes, sir. Absolutely.
Uh, yes. So
Can I,
it
can I,
was a
can I
very good
add one more
interaction.
point?
Yes, sir.
I wish to add something related with the antibiotic therapy in infections with atypical bacteria.
Yes, sir.
As you mentioned, like chlamydia, legionella, etc.
Yeah.
We use macrolides like azithromycin because
Yes.
azithromycin gets concentrated in macrophages.
Yes.
The cellular phase of atypical bacteria runs only inside the cells that are
Yes, sir.
macrophages. So bacteria is also hiding inside the macrophage and azithromycin is also getting concentrated inside the macrophage. So this is the most suitable antibiotic to deal with atypical bacteria. Moreover, azithromycin, if enters in macrophages, it remains there for more than 2 weeks. So we seldom continue the dose of azithromycin beyond 3 days or 5 days at maximum.
36
Because
hours.
once we complete the 3 dose or 5 dose schedule of azithromycin, it remains there in the macrophage for at least 2 weeks. And tissue macrophages have a longer life. They remains alive for weeks to months.
3 months.
So once we full that macrophage with azithromycin, we do not need to continue after 3 or 5 days. Thank you.
Thank you, sir. Thank you.
Yeah,
So I
there is
think the students are emphasized about atypical coverage. That's why I took a case that they should remember to also cover the
Madam,
atypical matter.
if you have got time, there are one more small question is there.
Yes,
Very
sir, please.
preliminary question. Which all traumatic wound antibiotic recommendation? Should we
See,
start?
okay.
Should we start one or wait till signs of infection wound site?
See, I am a ATLS faculty, and ATLS manual clearly tells you that there is no role of prophylactic antibiotics even for burns. In fact, I was invited as a faculty at Kochi, and there was one faculty who was telling to give antibiotics. So I pointed it out to the course director, and he came and apologized that this is a mistake from the faculty. There is no role of prophylactic antibiotics. There is a big no-no. Even when a surgery is to be undertaken, the prophylactic dose which is given, only single dose is given. Only single dose is given. Only if the surgery is prolonged and the duration of antibiotic is lesser, then one more dose can be given depending on the duration, but not otherwise. It is not a course of antibiotics. So
Yes.
that is a very important question, and it is a very important take-home message that there is no role of prophylactic antibiotics. Only certain conditions, like somebody is undergoing dental extraction and has a very high risk of endocarditis. So there are specific indications. So prophylactic antibiotics routinely big no-no.
Yeah. Here, in any wound or
Especially in
burns,
trauma. Yeah,
any
burns
wound,
and trauma,
burns
no.
or trauma, there is always aseptic measures are more important than antibiotic. What is the stress is here? We have to use aseptic precautions mainly to prevent infection. More stress is given to prevent infection rather than prophylactic antibiotics. What is everywhere it is being given nowadays. Even after surgery also, only aseptic precautions are more important, not antibiotics. Only if surgery goes more than 3 hours, then one more prophylactic dose of antibiotic is preferable. What are the
Yes.
guidelines even now at present status?
Yes,
I
sir.
agree with madam also. So it was so nice. Now, no more questions. Now I request all the delegates to give a feedback, and if you fill the feedback and submit it, then you get the e-certificates from our department. Thank you so much for all the delegates attending here. Now thanks will be given by Dr. Kiran Patil, Professor of Emergency Medicine.
Hello, good evening, everybody. We sincerely thank Honorable Chancellor, Sir, Dr. Prabhakar Koreji, who has always been encouraging such academic activities and has been a guiding light to us. We thank our Honorable Vice Chancellor, Sir, Dr. Nitin Gangane, for his esteemed presence and valuable advice. We thank our esteemed Chief Guest and the resource person, Dr. Varsha Shinde, Madam, Professor, Department of Emergency Medicine, D.Y. Patil Medical College and Research Center, Pune, for accepting the invitation and a wonderful informative talk regarding the subject. Thanks to Dr. M.S. Ganachari, Registrar, for guiding us in all aspects. We are very much thankful to our beloved Principal Madam, Dr. Mrs. N.S. Manshetty, and Vice Principals, Dr. Rajesh Pawar and Dr. Vishwanath Patel Shetty, Dr. Arif Maldar, Medical Superintendent, for their continuous coordination and being instrumental in such academic activities and working with indomitable spirit. We thank our Medical Director, Dr. Colonel M. Dayanand, Sir, who has always been guiding and encouraging us for such events. We also thank senior faculty and Dr. C.S. Sanikop and the resource person, Dr. Srinivas Kulkarni, HOD of Emergency Medicine, and all staff faculty members of Emergency Medicine, Dr. R. Rajesh and Dr. Ajay Pawar, and postgraduates, Department of Emergency Medicine. We profusely thank the stakeholders, delegates who have been the backbone in the scientific session of this evening. I thank the support departments for the event, the Dome, IT department, engineering departments, electrical department,
for their untiring efforts to make this event successful. Thank you, one and all.
Thank you so much, madam.
Thank you, sir. Thank you very much, sir.
We take a photo, madam. We like that only. Come on. So, come here. Thank you so much. Thank you. Good night. Have a nice day.